Good morning, hello, good evening, wherever you are watching our virtual kickoff from Hello. Thank you for tuning in to our second virtual HIV Prevention and Education Summit. We are delighted to have you with us, and we're excited to share with you all of the things that we have planned for you this month of our AIDS Education Month, which we always celebrate in the month of June. My name is Dr. Tashina Reeder. I am the director of the Community Health Training Alliance here at Philadelphia Fight. And with me, I have Kyle.
My name is Kyle Chvasta. I am the Public Programs Manager here at the Community Health Training Alliance Education and Training Program at Philadelphia Fight Community Health Centers.
And so today is our kickoff, right? We're kicking off our AIDS Education Month. And typically on the first day of our virtual programming, we always talk about the day of what to expect throughout the month of June. And with us, we have Jane Shull, the CEO of Philadelphia Fight. And so just to give you a review of what to expect for today's webinar, we want to have a conversation with Jane about where Philadelphia Fight is and talk about our annual summit and how it came about, and to also share with you about the rest of the month and some of the things you need to know to prepare yourself to enjoy our robust schedule of educational program. So without further ado, I would like to introduce you to Ms. Jane Shull.
Hi, morning. I also, on behalf of Fight, would like to welcome everyone to, it's really hard to believe, our second annual virtual HIV Summit. It's sort of astounding we're having to do this for a second time, but of course we have hope now as the cases of COVID are crashing as a result of increases in COVID vaccination, at least in the United States. And I do look forward to seeing all of you in real life next year at the convention center. So I was asked to say a few things about us, COVID, and other things that have been happening in the last year. Needless to say, the pandemic has presented many obstacles and challenges to us, as to everybody, since it started. We had to very rapidly change many things that we were doing and also the way in which we did them. I would say, fortunately, if this pandemic had to happen at all, which maybe it didn't, but that's like in another world of politics. Fortunately, it did occur in a pretty wired world in which telehealth was a viable option for anyone with access to a phone. And of course, that's not everybody. But one of the things we were able to do was find I don't know, somehow I got muted again. But anyway, we could have actual visits for people without smartphones. One of the first things that happened in the COVID-19 pandemic, as I think probably you know, is that poor people lost access to broadband and the internet. All the computer labs, including the Free Library and other big providers, were forced to shut down, as were we. Nevertheless, we were able to do telehealth with many people, and we never stopped seeing patients on site. So we also had to rearrange our spaces to make them safe for everybody. For a few months, that meant anybody who had symptoms consistent with COVID came to the LAC Center. And the reason was because the LAC Center, as the HIV Center, had very strong infectious disease support there. Anybody who did not went to John Bell or to YHEP. This was disruptive for everybody, although we also divided up our clinicians, so there'd be at least some familiar places every place. It was similar for our education programs. Very quickly, Cheetah, the program at Fight that produces this program and all of our community education, moved its programming to online platforms, making it accessible to anybody who could get access to the internet, with the option of listening in for those who only had phone access. Project Teach figured out they could hold classes online too. And what they did is they developed a library of iPads that they could lend to participants, and it was complete with a data plan, so that people did not use up all the minutes available in their own data plans in order to do the teach class. We offered home HIV testing. ICJ, I mean, last year we had the Prevention Summit online, and also ICJ sponsored its major conference, the Prison Reentry Healthcare Summit, online as well. And they also did a lot of home visits to make sure their clients were okay. We have had very good attendance at all of these programs, all of our online programs. And as the world starts to open up again, which it is doing in Philadelphia now a week early because the case numbers are crashing, we are going to be able to have more that happens on site and online. So then we have a couple other issues. ICJ, among other things, did a lot of home visits to make sure that the people who they were concerned with, meaning people who were returning citizens from prison or jail, were okay. I think it's really important to acknowledge that more than anyone, people who were incarcerated suffered from uncontrolled COVID in the United States and in Philadelphia. We all heard about the outbreaks in nursing homes, and this was terrible, as elderly, disabled, and other vulnerable people died in large numbers, isolated from their loved ones. But what you may not hear as much is it was worse in prisons. The worst outbreaks were in prisons. In Philadelphia, we know that a very radical lockdown was tried. And the consequence, because meanwhile, a lot of their staff would not show up on any given day, there were people who were locked in their cells for days at a time. And sadly, we saw violence between cellmates at a much higher rate than usual. And they had COVID outbreaks. But we barely hear about the COVID crisis in prisons. And I know everybody listening to this knows why. COVID, like HIV on steroids, has basically been shining a light on the racial and social inequities in this country. People of color have been infected more than white people in Philadelphia and everywhere. Some of it has to do with jobs and who in America tends to be overrepresented in frontline jobs with zero time off and with much less control over their conditions of work. Some of it is certainly access to healthcare. We've tested about 11,000 people, COVID tested about 11,000 people, FIGHT has, since the pandemic began. We're doing these tests in the community, by which I mean we have sites in North Philadelphia, both east and west of Broad, Tioga, Nicetown, Germantown, Kensington, near the epicenter of the HIV epidemic, South Philadelphia, where much of our testing is concentrated on recent immigrants, partnership with CMAC, documented and undocumented, and in Norris Square. And I can tell you that many of the people who we test from the beginning have been coming to us because their employers require it, don't pay for it, or because they went somewhere else in the past and got charged for the test. This is illegal, by the way. It's completely illegal. You cannot charge for this. But of course, it still happens. So if people don't have access to healthcare that's respectful and pays attention to their needs, they may not get a test. And as a result of that, they may infect other people and do so unintentionally because they didn't know they were infected. Language accessibility is also a big issue. Spanish, of course, but there's many other languages. I mean, we've been, with CMAC, who we work with, we've been up to 35 languages in some of our vaccination or testing events. And trust is, of course, is a big issue. I think if it weren't for the Black doctors in Philadelphia, our pandemic would probably have been a lot worse than it was. And the people running that program, notably Dr. Ayla Stanford, have been absolute heroes. I think based only on what they said that you could see was that they began their testing program because there was virtually no testing available in Black communities, and they wanted to remedy that in a smaller way. We were trying to do exactly the same thing for the same reason. One effect of that, though, I think, was to build trust in those communities in COVID testing and later in COVID vaccines. Similarly, what we're seeing with vaccines in this country is much higher rates of vaccination, whites versus African Americans and Latinx populations. There's been a lot of discussion about trust in relationship to this problem, and this is undoubtedly true. Groups that have historically been tricked and used in order to build the careers of white researchers, which certainly is what's happened. And of course, if you're our audience here, you know it's not just Tuskegee. Groups don't have that much reason to trust a vaccine that was rapidly developed. And at least at first, there was not enough information, there was no information about whether the trials had reflected the populations in the community where the vaccine would be deployed. But there are other issues here. For example, we know that many people in the communities that are concerned need vaccine opportunities after hours and on weekends, and it's not so available then. Except for some very dramatic events near the beginning of the vaccination campaigns, fully fighting COVID, you haven't seen this. And I want to acknowledge that we've been part of this problem, although we were trying to fix it. Our community vaccination campaign for people in the community, not our patients who are getting vaccinated here at FIGHT, but our community vaccination campaign is with the pharmacy partners, Sunray Drugs, who I want to say have been just wonderful and willing to go any place when we go anywhere they need us to. However, they don't have as much availability on weekends and after regular working hours. As we have done some canvassing in neighborhoods heavily impacted and starting to do it after working hours, I think we're starting to hear more about these stories. And these are issues. So as with AIDS, the lesson here is about equity, not treating everybody exactly the same, but taking into account the impact of historic and present discrimination in denying African Americans and Latinx people, especially, access to care. So the FEMA site would say, well, anybody can come to the convention center, but that's not what happens, because some populations have access to the internet. Poor people lost access to the internet right at the beginning and have not yet gotten it back. And therefore, when you have appointments only online, they're not going to be able to come. One of the reasons we did appointments on the phone was for exactly that reason. You could sign up on the phone for our community vaccination, but we're tiny compared to what happened at the beginning in that center. Also, some people have the money to park in Center City and some don't. Most people who I talked to were very reluctant to get on public transportation, especially a few months ago. So if you didn't have the money, you might not come into Center City. And some people have a history of trust, while many people are aware of histories of exploitation, and that just doesn't lead to trust. So you're not going to get an equal result unless you actually pay attention to issues that have to do with equity, not to treat everybody the same, but to do everything we can to make up for historic and present inequalities, to make it easier for people of color to get treatment and to get vaccines. And this is the second place where the role of the Black doctors was so crucial. We all saw what happened when they opened their weekend-long site at Temple University. People came, they flooded. It was open only to those zip codes where there was more need, because there was more minority population equity, because the wrong needed to be righted. Making vaccines available in reality, not in theory, also definitely needs to include education, because I think vaccines do represent hope. And I hope the people listening do not let their understandable concern overcome their natural curiosity, and that you'll educate yourselves about vaccines. We in the AIDS world, I think it's really important to remember this. We actually know something about this. AIDS is now a truly treatable disease. You can live a normal life with HIV and live a normal lifespan. The drugs themselves no longer make the great majority of people sick either. And all of this has happened because of AIDS activism, which I like to say whenever there's an opportunity to say it. It's happened because of AIDS activism. Because people in the very beginning refused to give up, refused to lay down and die, and fought back collectively and smartly and made all the difference in the world. But we saw the same issues with HIV medicine in the earliest days when there was medicine. When the first drugs, for example, AZT used alone without any other medicines, did very little good, and in fact may have done more harm than good, this was universally denied by the scientific establishment. I want to say I was there, and it's still not entirely clear to me whether they knew. They certainly should have, but they certainly all denied it. There was a big fight about this, and the doctors who were trying to say you're wrong tended to be silenced. What was interesting about that, we're talking about like the late 80s, early 90s, was the communities who had less reason to trust, and specifically many men who have sex with men who were African Americans, they noticed the reality. And they were very reluctant to take any HIV drugs. They were probably right about that. But then what happened was that many people also declined the next generation of drugs that actually did work. And people were not taking advantage of drugs that, although they had side effects, were probably, by which we mean very high percentage chance, going to keep you alive until drugs that were like what we have now, that are easier to take, came along. However, with education and with experience on the part of people with AIDS and their allies, that reluctance was overcome for the most part. And I saw it over the years in teach classes where people, you know, in the beginning, when you talk to a teach class, you really had to spend a lot of time saying, you're all right about AZT, because I always said that, because they were. But you need to think about these other drugs. I saw this start to change, and people would come into the teach class and they'd be on medicine, or they at least would come in knowing people who'd taken HIV drugs. And as they got the information from us, which we always tried to present in the fairest and least biased way that we could, they got it from us, but also, most importantly, from each other. Many became more regular in taking their medicine, and they lived. So similarly, with COVID vaccines, which I think the evidence does show do work and don't do more harm than good. And one reason why, by the way, is science knows a lot more now than 30 years ago. And a lot of that is because of research that was done around HIV and AIDS over the years, right? One thing to do is to ask people who you know and trust who have received the vaccine, and watch what happens and make your judgments accordingly. And for those who have received vaccine and are fine and are now protected with COVID, like people with HIV medicine did and came forward in the 1990s as it started to change, it's important for all of us to spread the word and let people know your experience and what we know about how it works. Because, you know, there's a lot of rumors, which I don't think it's helpful to repeat. So we don't really want to repeat them, but you know there's a lot of rumors out there. Finally, 2020, the COVID pandemic showed us, in case somehow we had missed this, that race and the terrible legacy of slavery and the legacy of Jim Crow and mass incarceration and police brutality, which are alive and well in this country, are not just the original sin of this country, but the ongoing sin. And we all need to do better. At FIGHT, one thing we are doing is looking at our healthcare outcomes, because, you know, we're a healthcare organization, to see if we see racial differences. And as we find differences, either looking at the numbers, do different racial groups have different outcomes in controlling high blood pressure or diabetes? Not just nationally, where we know they do, but here at FIGHT, and talking to people within our clinics and our patients about their own experiences so that we can work to address whatever problems we find. I think we also played an important role in presenting material in the last year to the general public. on these issues, which started to really come to the fore, be lifted up, and in some cases explode a year ago, right, this past weekend. Notably, our anti-Blackness webinar series that took critical race theory and made it real through a series of programs that focused on our community and our constituency, who we are, and the people we serve. And we need to keep doing this. We really need to keep doing this. Although we have all been obsessed with COVID this year, I want to say something else about AIDS. HIV has not gone away, as we all know. The sudden jump in new HIV cases connected to IV drug use, a problem that was close to disappearing before the opioid and fentanyl epidemic, that jump continued in the year of COVID. There are some issues related, I think, to this, to HIV and COVID, that are important to know. Right at the beginning, there was no evidence either way that HIV status would affect what COVID would do to a person who's HIV positive. Because there was no evidence that it posed a danger, the word became that it doesn't. This was something that should not have happened. You didn't have evidence, maybe you didn't have evidence yet. That is incorrect. That's wrong. It's not accurate. Does HIV status, positive status, does increase the risk of serious illness or death. And then what happened in Philadelphia was very interesting and illuminating. While the rest of Pennsylvania, under the leadership of our then health secretary, Dr. Rachel Levine, the first trans woman to hold this position anywhere in the United States, under her leadership, the rest of Pennsylvania made HIV an eligible category in Group 1A. Remember all those groups at the beginning? Philadelphia did not. It's a long story, but Philadelphia is allowed legally to go its own way and make up our own rules. This kept up. HIV was not in any of the early groups, even after there was good data published that demonstrated, well, no, guys, you're wrong. HIV is a risk. And then this is what happened. One AIDS patient announced he was going to sue the city. This got published in the Philadelphia Gay News. The patient was using a pseudonym, but actually he's a person we know and an activist. The story they published showed a map of the entire state of Pennsylvania in green, except for Philadelphia County in the corner looking really tiny in red. HIV persons were eligible in the whole green part, but not in the red part. If you had a map of population in Pennsylvania, Philadelphia would be much bigger. But in terms of geographic area, we're not very big. Very dramatic map. They published it online. And then within half an hour, the health commissioner's office was on the phone to the editor at PGN. And within a day, the health department reversed their decision. In other words, with COVID, as with AIDS, activism works. If you want change, be an activist. And in fact, I think the final way really in which AIDS and COVID teach us the same lesson is activism. I don't think that it's enough to notice and bring forward all of the ways in which the same people who were impacted by AIDS because of past history, racism, and current discrimination are impacted more than white people by COVID. It's not enough. The point is, we need to change this reality. We need to stay alert. We need to work together. We need to remain committed to change. And I think that is what we will be trying to do at FIGHT. And I know that many of you do as well. So that's what I have to say. And thank you for your time and your attention.
Thank you so much, Jane, for sharing just some of the history of HIV and AIDS, and also speaking to our current pandemic of the COVID and its intersections with health inequities that many people of color have faced and continue to face at this time, but that ties into our theme of the conference, which is why we decided it's important to have some hard conversations around social and racial inequities around healthcare. It's no secret, 2020 took us all by storm, and we were forced to really face some hard truths, or at least witness some things that we oftentimes would avoid or turn the other cheek. And last year, even into this year, we had to really look at some of our own realities. And so part of us creating or having this theme is to have at least an educational platform to address these issues as it relates to healthcare, but also within our systems. Because we all know that the issue of race, racism, systemic racism, all these inequities or inequalities will not go away overnight. But we do know it takes an effort on all of our parts to face some hard truths with ourselves about our own bias and microaggressions, and how we perpetuate these systems and behaviors at play to make true change. And so having this platform to have some conversations around these topics as it relates to healthcare is a first step, right? To broadening our awareness for personal growth, but also how we can affect change within our organization, starting with policies and procedures and our own behaviors. And so I'm really excited to, be a part of this year's programming as we speak to these issues so that we can grow and learn together to make true change. So with that being said, I'm sure you probably will have some questions about this year's summit. So feel free to ask your questions in the chat. But in the meantime, we're going to share with you things to expect, things that you may need to know to navigate through the rest of this month and to attend some of the webinars. And so we do have 15 webinars for the month of June, and we have programming for Youth Central. So I'm going to allow Kyle to speak to the 15 webinars first around CEUs, registrations, and all of that.
Absolutely. Thank you, Jane, and thank you, Dr. Reeder, for kind of framing the call to action for which this summit is framed in. This year, as Dr. Reeder mentioned, we are offering 15 webinars that speak to the issues of HIV prevention, research, and healthcare justice. We are offering 3 webinars each week. The first and the last week are shorter weeks, so the weeks are a little more smushed together. But the middle of the week, it's every Monday, Wednesday, and Friday. All webinars are from 11:30 a.m. until 1 p.m. They're all free and hosted via Zoom. After today, we will be hosting 3 webinars this week. First one talking about stigma, HIV cure research in Philadelphia, which is our annual update in conjunction with the Wistar Institute, and on behalf of me, myself, and I, which is a webinar that addresses barriers in healthcare as it pertains to language. Then the remainder of the month, we have webinars about PrEP, inclusive and affirming language in care provision. We have some Hep C webinars. We have a Hep B webinar as well. And just a number of other really exciting offerings that are framed within this call to action to address disparities in healthcare, decenter our whiteness, and, really look at our practices and how we go forth with program planning, implementation, and, our own hand in perpetuating systems that create adverse health outcomes. So, like I said, all webinars are free. The program is approved by the NASW for 15 social work credit contact hours. Each webinar is worth 1 unit, and the entirety of the program is worth 15 units. And to obtain those CEUs, you just have to go to the webinars, take part in a survey, and then just pay for the certificate processing. Now, the whole conference is 15 webinars, and if you go to the whole conference, you get a discounted CEU rate. But if you go to individual webinars and don't go to all 15, it's slightly more. So you have to pay per webinar. So that is more or less the summit in a nutshell. We have a lot of great things to offer. We're excited about all the experts joining us this year, and not just joining us this year, but joining us around that call to action as well. All right, and it looks like we have, if you have any direct questions about CEUs, you can email us at cheetah@FIGHT. And with that, I would like to hand it over to Dr. Reeder to discuss our youth offerings.
Okay, so excuse my excitement, but I absolutely love our Youth Central component of our prevention summit. And so we have some exciting programming for youth. And we realize, a lot of our youth will not log into Zoom to sit and listen to a presentation. So we decided this year to have all of their program on Instagram. Our youth have their hands or their mobile devices in their hands, and they're really actively involved in your TikToks and your Instagram and all of those social media platforms. And so we decided to use our Youth Central Instagram page to host programming for our youth. And so, and it's all free. And we have on June 8th, all of Youth Central program first will be on Tuesdays and Thursdays throughout the month of June. And so we have a schedule. We have some more scheduling actually taking place as we speak. So for what we have right now for Youth Central, for youth between the ages of 13 and up, June 8th, we have the Teen Library who will share about all of their resources specific to teens and their supports for teens and things that teens can become involved in to enhance in their literacy skills, to learn just about things around health and wellness. And it's all at the teen, at the library, the Philadelphia Library, or the Library of Philadelphia. Did I say it correctly? But you guys know what I mean. The Library of Philadelphia, but they have a teen library component and they specialize in different things, all things youth. Then we have on June 10th, we have a youth who his name is Khalil Smith, will be speaking to his fight with cancer. The title of his segment is called I Dogged Cancer and Now Transforming Lives Through a Message of Inspiration. So he shares a story with youth and really is a big advocate on health and wellness around taking care of your health. Just because you're a youth doesn't mean you should ignore the signs your body's giving you that something's not okay. So he shares a story and hopes to empower youth to take charge of their health as well. Then we have on June 15th, Nakia Outland. She is the founder of Prevention is Key, and she's going to be talking to our youth about, let's talk about prevention. So all things prevention will be discussed with Nakia on June 15th. And on the 22nd of June, we have Dr. Smith, who will speak to us about jumpstarting your journey into adulthood, tools for success. And so he is a big advocate and supports youth around having tools as you enter into adulthood. And so I think it's really important for our youth to understand, how to budget their money, things that can help them prepare themselves for adulthood. So we're excited about all the other things that's coming up to be scheduled for Youth Central, and it's all on our IG page. And so to find out how to follow, just go to our website and all the information is there in terms of how you can tune in. All of the programming, what happened during the lunch hour from 12 to 12:30, some may go until 1. And so we're excited to have that and as a part of our virtual platform again this year. So please, if you have a youth, of a youth or youth organization, share this information to make sure that youth will check it out. But as always, we always save our recorded educational offerings for future views. So if you want to share the information, share it to a youth organization, you're able to do so. And so that's Youth Central. So that's what we're offering in a nutshell for the month of June. Any updates or any changes, you will be first to know through our email. So be sure to follow our website. You have our emails, extra questions, so we can respond to your inquiries. And I think that's pretty the gist of the month of June and what we have to offer for this year's virtual summit. Kyle, do you have any last thoughts? Jane, you have any last thoughts?
At the moment, no. We just hope that you'll join us for all the webinars. Please register for them individually. It's going to be great.
Jane, do you have any last words?
Well, I just would want to urge everybody to take advantage of all of this wonderful program. I mean, you know, it's like having had a year to perfect it. I would say Cheetah has perfected it. And there's just a great lineup, as you heard. So hopefully everybody will come to more.
Yeah. So get excited, everyone. Get ready to be informed, to be empowered, to make some change. And so this is our call to action to you. Be sure to register and to attend our summit this year throughout the month of June. Thank you all for attending and have an amazing rest of your day.
Time to step up, prep up.
Step up, prep up.
To help keep you free from the risk of HIV.
From the makers of Chvasta, there's another PrEP option, Descovy for PrEP, a once-daily prescription medicine that helps lower the chances of getting HIV through sex. It's not for everyone. Descovy for PrEP has not been studied in people assigned female at birth. Talk to your doctor to find out if it's right for you.
Step up for health and body.
Prep up for your one and only love, or many loves.
For kings, this queen, and you royals in between.
For my now.
Our now.
And my future.
Our future.
Step up, prep up.
Descovy is another way to prep. Descovy does not prevent other sexually transmitted infections, so it's important to use safer sex practices and get tested regularly. You must be HIV negative to take Descovy for PrEP, so you need to get tested for HIV immediately before and at least every 3 months while taking it. If you think you were exposed to HIV or have flu-like symptoms, tell your doctor right away. They may check to confirm you are still HIV negative. Serious side effects can occur, including kidney problems and kidney failure. Rare life-threatening side effects include a buildup of lactic acid and liver problems. The most common side effect was diarrhea. Tell your doctor about all the medicines and supplements you take, or if you have kidney or liver problems, including hepatitis. If you have hepatitis B, do not stop taking Descovy without talking to your doctor. Ask your doctor about your risk of HIV, and if Descovy for PrEP is right for you.
Words are loud, but actions are louder.
Step up,
Prep up.
With Descovy for PrEP.
Get help paying for Descovy for PrEP. Learn more at stepupprepup.com.
Today we are in Center City, Philadelphia, Pennsylvania, at one of our over 300 community-based specialty pharmacies. A community-based specialty pharmacy is a full-service, fully accredited specialty pharmacy, but it's embedded in the communities we serve, either near or within health systems and medical office buildings.
One of the unique things about a location like this is it takes a team to manage these patients with such high complexities of specialty care.
The pharmacist will provide thorough counseling on a disease state as well as medication that the patient is taking. Pharmacists will also assess for potential barriers to therapy and work with the patient and their providers to overcome barriers with a goal of improving outcome.
So one of the things that the specialty pharmacy does is it gives them a complete care regimen that is monitored very closely to make sure that they're taking these medicines properly, because the most expensive medicine is the one that's not taken properly. I think one of the things that's unique about our role is that we get to be a liaison between clinics, hospitals, healthcare systems, and our pharmacists. We have access to limited distribution drugs because of our scale.
The response has really been extraordinary, particularly from our payer partners, our partners in the pharmaceutical industry, and also patients and providers.
It's a privilege for all of the staff here. There is no small job at a location such as this. Whether you're the pharmacy manager or whether you're the technician just ringing out people at the register, we are connecting with patients at a very high level.
It feels great that we're able to help our patient. At the end of the day, when I go home, I feel like I made a difference in someone's life.
CCN Pharmacy, we have specialized in HIV care since 2006. As a pharmacist at CCN, our care teams look forward to working with you on a one-to-one basis. We will fill all your medications every month and deliver them to you when and where you are. My favorite part about working at CCN is getting to know you and helping with your medication needs.
We value our relationship with you, and that's why you'll be introduced to your dedicated care representative and a pharmacist. They'll work with you every month to provide that comfort and ongoing familiar support. Earning your trust and supporting you every step of the way is our goal. We're more than just a pharmacy.
We are here for you as a person without exception. We know the struggles and the difficulties that you may face on a daily basis. We understand you. We speak your language.
As a social worker who previously worked at an HIV clinic, I know about barriers to care and the need for social services. Understanding this helps me to help clients become and remain undetectable. And that way, we are more than just a pharmacy.
We see you, and we'll meet you wherever you are in your journey of life. Yeah, we fill your prescription medications, but we are so much more than just a pharmacy. We can't wait to meet you and work alongside you.